So it is my great pleasure to be able to welcome you to this closing session. It's great to have a gregarious audience still filled with energy. And please, keep going. Well, I'm just giving ceremonial or ritual remarks, so it doesn't matter. But the final session is entitled From Research to Practice, New Collaborations, New Ways of Mediatizing Health, with a question mark. We are delighted, we here I guess being Dan, Hallin, and myself, delighted to have four wonderful panelists joining us. We're going to introduce them. Each speaker will talk for about 10 minutes, and then we will have questions focused on this topic. So, as you've probably heard already, Richard Besser is the Chief Health and Medical Editor for ABC News, a pediatrician and infectious disease specialist and epidemiologist, I might add. He came to ABC News from the Centers for Disease Control and Prevention, or CDC, where he served as the director of the Coordinating Office for Terrorism Preparedness and Emergency Response. And also he was the interim director from January to June 2009 when he led the response to the H1N1, better known at the time as swine flu epidemic. The author and co-author of hundreds of presentations, abstracts, chapters, editorials, and publications. His first book is Tell Me the Truth, Doctor, Easy to Understand Answers to Your Most Confusing and Critical Health Questions. Lori Dorfman is the director of the Berkeley Media Studies Group, which is a project of the Public Health Institute. She is also an associate adjunct professor in our School of Public Health. Professor Dorfman's recent research examines news and advertising portrayals of various public health issues, including children's health, nutrition and agriculture, food and beverage marketing, paid family leave, racial discrimination, violence, alcohol, tobacco, and other drugs. She's very busy. Dr. Dorfman co-authored a major text on media advocacy, public health and media advocacy, power for prevention, and news for a change. An Advocate's Guide to Working with the Media, and also Reporting on Violence, a handbook for journalists. Dan?
Okay. Ed Wasserman is Professor of Journalism and Dean of the Graduate School of Journalism here at UC Berkeley. Before coming to Berkeley in January 2013, he was for 10 years the John S. and James L. Knight Foundation Professor of Journalism Ethics at Washington and Lee University. Dean Wasserman writes and speaks widely on matters related to media rights and wrongs, technological change, and media ownership and control. His academic specialties include plagiarism, source relations, confidentiality, and conflict of interest. From 2001 to 2016, he wrote a biweekly column on the media that was distributed nationally by McClatchy Tribune News Service. Prior to his career in academia, he spent 20 years working for news organizations in Maryland, Wyoming, Florida, and New York. Mohan Dutta was introduced yesterday, but for those who are new, he is Provost Chair, Professor, and Head of the Department of Communication and New Media at National University of Singapore. He teaches and conducts research in international health communication, critical cultural theory, poverty and healthcare, health activism in globalization politics, indigenous cosmologies of health, subaltern studies and dialogue, and public policy and participatory social change. His books include Communicating Health, a Culture-Centered Approach, Communicating Social Change, Structure, Culture, Agency, and Neoliberal Health Organizing. He is also an active participant in creative production, script writing, direction, and theater for social change. In his most recent performance work, he served as the visiting artistic director for Ritwik, a grassroots group in West Bengal, India, working on performance for social change.
So, by the way, that was Dan Hallin, Professor of Communication at the University of California, San Diego. We will begin with Lori Dorfman.
Okay, I'm going to stand and go. Good afternoon, everyone. You haven't all fallen asleep after lunch. This is post-prandial, right? Okay, so the dangerous spot. This way I can see you all. So thank you very much for the invitation. This has been fascinating. I feel like this panel shifts us from the thinking part to the doing part. So so what? What do we do about all this mediatization? And it's not that we don't think about what we do, but that's just how I've divided in my mind, mostly because I don't get to sit outside the world of my work and think about it for a whole 2 days and think about the theory. In fact, I haven't delved, I think, this deep into theory since my dissertation days, which our last panel will be happy to know involved participant observation in newsrooms, watching how the sausage was made, along with content analysis. So that's the basis of my understanding, and I want to tell you what brought me to an interest in this intersection between media and journalism in particular and public health, and just give you an idea of what we do and the perspective that we take, and then we can put that into the conversation. So a couple of things. The first thing is that throughout the conference, we, I think, have conflated a couple medicine and health, and I want to disengage those for just a minute. In public health, on the other side of the campus, we think about a distinction between medicine, which is happening very downstream, usually after somebody gets sick, and public health, which is happening upstream before somebody falls into the river of ill health, as it were. And I won't tell you the whole story, but there's an upstream, downstream story that we like to tell, and they aren't mutually exclusive necessarily, but definitely there is a distinction. And when you look at the data, what you find is that medical care accounts for less than 20% of overall health status. So if that's the case, then that means there's a lot of other things impinging on population health, and that's another distinction. So in public health, we care about populations at the population level, not about any given individual, but what can we do that will create environments where health is going to be the outcome rather than disease. And as the WHO has stated many times, health is more than just the absence of disease. So we like to talk about the social determinants of health. That brings us to education as a determinant of whether people are healthy, or their income, and all those big picture ideas. So if that's true, if you go to public health school and you learn that the best way to increase the health among a population is to improve the environment in which they live, then what you need to do is pay attention to that environment, how it got that way, and who makes it that way, who keeps it that way, who sets the rules, who can change the rules. And in our day and age, that is by and large policymakers. And so if that's the case, then I, as a public health person, want to have a conversation with policymakers. I need to pay attention to what they pay attention to, and they pay attention to the news. So that's what brings me as a public health person to an interest in journalism in particular, because of the way it sets the agenda for our public debate, and importantly, the way it helps frame that debate. It used to be said that the news doesn't tell you what to think, it tells you what to think about, right? But I think that has profoundly changed, and in fact, the way news is presented, as we've been discussing the last 2 days, and the way things are mediated has an enormous impact on what people think is possible and what the solutions can be, which is what I'm most concerned about. So at BMSG, at the Berkeley Media Studies Group, what we do is try to take what we learn about the news, and so we study the news in all those various different ways to try to understand how is responsibility for health framed. Is our stories in the news media putting responsibility at the feet of individuals to take actions on their own behalf or on the behalf of their families to improve their health? Or does the news help illuminate those social determinants of health and help show the pathway to change for whole communities at once through policy? And that's usually where we are headed, because we want to help people understand the social change process and how they can become active participants in that change. And that's where we arrive at the term media advocacy, which we put in contrast to social marketing. There's a lot of health communications where people think, wow, these marketers seem to know what they're all about. They seem to know how to get people's attention and to engage them. What if can't we do what Coca-Cola does? Can't we use their techniques and then just sell brotherhood instead of soap, as it's referred to often? And the problem is that we can't do that. Mohan showed us yesterday what the very serious problems with that are in terms of who has power in that relationship. But even if we could, even if it worked a little bit better, we would have to do it all the time, because the environments would never change. And we can never compete with the kind of resources that one company has when it wants to put out one new candy bar compared to what the Centers for Disease Control might spend on a campaign. We were working with a community group at one point that was concerned about the birth weights of teen mothers because those birth weights were lower and their kids would have more health problems if they had low birth weights. They wanted to increase their nutrition and they wanted to use the 5 fruits and vegetables a day idea. Let's get 5 fruits and vegetables to these teen mothers. They'll have better nutrition, better birth weights for their babies, and wouldn't that be a good thing? And we said, well, maybe you will be more successful than the National Institutes of Health and the CDC, and you'll actually get people to see that phrase and know what it means. And then maybe you'll go way beyond that success and you'll get them to desire the fruits and vegetables. Where will they buy them? So we suggest that you start with that question, and in the process of changing policy to make sure those fruits and vegetables are accessible to the people who need them most, you have to explain why. You have to say why public resources are necessary, why it's worth our time, and in that context, the education about health can be included in the action of social change. And this is a struggle even in public health. I'd say we are the outliers. Most people come into public health thinking that if they just get the right message to the right person in the right way at the right time, they will do the right thing. And you know, sometimes it works. Some of us know that if we just kind of break a sweat once a day, we'll live a longer, healthier life. And so we got up and exercised, or we walked a little bit further. And some of us know that, but the knowledge is not enough to create the action. So we have to create the environments that make that difference. And that gets to the root of what public health is all about, which is social justice. In contrast to market justice, Dan Beecham gave us this nice delineation between these different approaches to the world. And what is important in those different approaches to the world is how government is seated. And this is going to bring me back to journalism in a second. So in a market justice point of view, you are responsible for yourself and your family. You take that education that you get about exercising more and living longer, and maybe you can have the resources to apply it to yourself, and there's some good that can happen there. But the idea is basically that you're on your own. And if you're going to use communications in that context, it's about getting messages to individuals in that top-down way so they can be healthier, and sometimes that works pretty well. Not quite at the population level we'd like it to work. What that means is that if you have an approach to government in that rubric, government is an interferer. It's somebody who's interfering with the relationship between you and your family and what you want to do. And the idea of communications in that rubric is as a consumer. You're a consumer of communications. From Dan Beecham's social justice perspective, it's slightly different. In that sense, it's not just about you or your family, but it's about the community that you live in. And the values that are brought to the fore there are values of interconnection, not just the values of personal responsibility. If you consider communications there, that leads to communications about participatory democracy and helping people raise their voice, not just giving them top-down messages. It means that you see government as a protector and want to engage government in that protection and hold government to account to protect the population. And that's what circles back to journalism in my mind, where we now have a whole profession that is about holding government to account. And it gets kind of tricky there because sometimes government does what we want and usually it doesn't do what we want enough. And it's a very tricky role, I'd say, particularly for places like the Centers for Disease Control that are charged with the public's health, but yet might not be going as far as some of us would like to think, and might always be under attack from their perspective from journalists. So it gets kind of tricky there. At BMSG, what we do is try to work on the side where we're helping people raise their voices based on the issues that they want to pursue at the local, state, and national level to improve environments so that we can have healthier populations. And we do that by studying the news media so we understand what the starting point of the conversation is. We can help them anticipate what their opposition is going to be. And then we work with them in capacity building mechanisms so we can help them understand that their media and communications isn't separate from their strategy, so we can help them have the courage of their convictions, so that the things they feel in their heart and think in their mind can come out of their mouth in a way a reporter can write down. So there's a skills development piece there. And we do that in the service of creating environments where whole populations can be healthy.
You've changed the mouthpiece. You know something I don't know. Thank you very much for inviting me here. I'm Ed Wasserman. I'm the Dean of the Graduate School of Journalism. It's a great pleasure to be amongst media scholars, and it's a particular thrill to be on the same program as heroes of mine like Mike Schudson and Daniel Hallin. It was a pleasure also to meet the person who heads the media program at the LSE, my alma mater. When I was there wasn't yet a media program. I'm sort of mindful that journalists are typically, in collections of media scholars, journalists are more or less the lab rats and objects of study. And I was kind of, I was sort of playing around with different themes, things that I might be able to share. I'm not a media scholar anymore. And I thought that what I would do is perhaps pull out a case. We'll call it a case study, although it doesn't really have the rigor of one. It derives from a phone call I got from a reporter named Trudy Lieberman, who many of you know. I think she's just a first-rate health and medicine reporter, and she was doing a piece for the Columbia Journalism Review about coverage of health, and she wanted to know what I thought of the state of play in coverage of health. And I thought about it for a moment. We talked for a while, and I said, you know, it strikes me that the biggest health issue in this country of the last decade has been the Affordable Care Act. This was right, I think, either just before or just after the election. And yet I can tell you, as somebody who pays a lot of attention to the news, that I don't really have a clue about the Affordable Care Act. I mean, I have, except for sort of vague ideas of universal coverage, and there's a lot of disappointment it didn't go single payer, and there's some floating around in the world of media tropes. I have some clue, but the depth of my knowledge of this immensely important area of public policy is abysmal. And I thought, well, gosh, you know, I wonder why. And so I'm sort of playing with that, you know, so I want to talk a little bit about the coverage of ACA as being revealing of problems in our approach to covering, the journalism's approach to covering healthcare. And in particular, I was tickled by mediatization as a concept, which I'll confess I had not really. I know people in this room have written entire books or libraries full of works on mediatization, but it was a cool concept and one that we have been, without using the word, wrestling with in the journalism program as well, because one of the things we try to do is to graduate very, very competent journalists with a very deeply critical stance toward journalism. And we try, marrying those two realities is not easy. Mediatization gives us a handle. So I wanted to, and I'm taking this to mean, and if this is the wrong definition, you better stop me now. In part, it means the way that media-favored themes eclipse areas of knowledge and absorb emphasis and attention from factual narratives that would be more revealing of the subject at hand. So they're kind of distractions, but they're media-friendly distractions, and the media necessarily glom onto them. So let's start with the essential elements of the ACA, right? There was an individual requirement, for those of you not in this country or those of you who are asleep at the switch as I was during the election, there was an individual mandate. Everybody would have to have life medical insurance. There would be subsidies to enable people to buy, if they couldn't afford to buy the insurance. There would be insurance exchanges where appropriately approved and adequate coverage packages would be made available, right? And then there was this goal of substantially widened, although not universal coverage, but substantially widened coverage, largely through the subsidies and through the expansion of Medicaid, which is the federal state program for the poor. Now, if I put on my hat as an assigning editor, I have to say, wow, you know, this is a pretty rich package of policies here. There's a lot of cool things to explore. There's a lot of reporting that needs to be done, right? What's the adequacy of coverage going to be? What's the coverage going to look like? How many people are actually going to have coverage that don't have it now? What's it going to do for the actual access to care? What about the mandate? How punitive is the mandate? Is it really going to force people into the marketplace? What about the logic of mandating and requiring a legal requirement on people to buy a privately brokered product? What about the cost of care? I mean, we're at 18% of GDP. Is that part of the deal? What about the health of the insurance industry? Are they going to own? Are they dictating the terms of this thing? How beneficial? How much of a sweetheart deal is this for them? Health outcomes? Are we going to be able to track those? Are we going to see are people getting healthier? And then, of course, the whole question of politics of Medicaid extension. So the ACA becomes law in March 2010. As of March 2012, before it had been rolled out, 2 years later, 56% of likely voters favored repeal. Right? They wanted to repeal this law. It hadn't even taken effect. A second poll, same time, March of 2012, only 37% of people favored the law, 46% opposed it. Right? Its unfavorability rating in a Kaiser Family Foundation poll remained about 47% in September 2014 and 16, right? It was higher, favorability was higher in 2015 than it is today. So alongside this was a huge slide in the popularity of just about any governmental initiative in the healthcare sector, right? 2007, as the presidential primary season was getting underway, people were asked whether the government had a responsibility to see to it that people had health care. Right? 64% of respondents answered yes. This is 2007. By 2014, that 64% had fallen to 47%. There had been a wholesale repudiation, an undermining of the idea that government had some sort of affirmative responsibility to make sure that people got health care. Now, as this woman Sarah Cliff noted on Vox, 6% of the U.S. population would gain coverage after passage. 80 million Americans already had health insurance through their employers. So most of us, as she pointed out, aren't experiencing Obamacare directly. We're learning about it secondhand from news sources and from people that we talk to. So this is very much a wonderful candidate for the centrality of the news media in conveying these large-scale understandings of realities that we're not experiencing firsthand. And then, of course, you had the signature moment, the so-called rollout debacle in October 2013. Government computers crashed, didn't anticipate the crush of public interest, right, leading to delays, a spreading stain of program failure. Enormous press attention went to this, enormous. Politico, the authoritative DC political website, had 14 front page, as we used to say, headlines on the rollout. The Washington Post, 4 top news stories were on their computer debacle. And 4 top op-eds were about Obamacare. The website as a disaster became this benchmark theme. Right? So Obama himself blamed the 2016 coverage of premium spikes for stampeding public unhappiness with the system. But I mean, I think you'd have to say that's not what was going on here. What was going on here is the media weren't covering ACA in any meaningful sense. And I tried to indicate to you what I would have done as an assigning editor if I actually cared about covering the story. But what were they covering under the name of ACA? I think what we find, and this is not a particularly deep observation, but I think what we find is that ACA ran afoul of strong ideological currents that tethered it to this various discredited doctrines. Ironically, since ACA has its roots in a very, very conservative approach that was used by Mitt Romney, who was governor in Massachusetts, and it was this conservative alternative to state-sponsored universal insurance plan. So what was the media covering instead of ACA? Right? So I identified 5 different themes. First, there was the general theme of governmental incompetence. This is a favored part of American ideology. It spans political affiliations. Even liberals agree government can't do anything right, although they take the position they should continue trying. It draws from this venerable political trope of bureaucratic inefficiency and bloat. So first of all, you're starting with the discrediting of the public sector as an effective means of doing most anything. Then you have this second theme, the erosion of personal choice. All right. Here, in the case of the ACA, consumer sovereignty, the patient as consumer, that model was uncritically embraced. And ACA would have the inevitable consequence of taking choice about medical options and medical treatment away from patient and doctor. This was just posed, this was asserted, it wasn't really proved, it wasn't even borne out, it wasn't even possible to delineate the ways in which patient-doctor sovereignty or patient-doctor authority would be undermined, but there you go. Erosion of personal choice was pretty much embraced as true of ACA. And it had Ben Carson, when he was still running for president, ACA, he described as the worst thing that has happened to this nation since slavery. Got away with that. So you have governmental incompetence, erosion of personal choice, and then the question of a business failure. In its own terms, ACA was fated to fail. It was going to lose money, right? The initial evidence of low enrollments, and there was evidence of premium increases seen as a failure rather than as predictable and short-term market responses. And then over time, fourth point, the ACA came to be accepted as a proxy for Obama himself. Obamacare and Obama became inflated. And so all of the rhetoric and all the abuse and all the distortions and whatnot and criticism directed at Obama, this was dragged into that line of fire. And then finally, ACA became a convenient symbol of the crisis of modern liberalism. And it became an appropriate target for that reason alone. So and my point here is this mediatized discourse pretty much excluded consideration of Obamacare as a system recalibration with varied impacts on various players. And it ensured that that he had a program that was plummeting in popularity before it was even implemented, and it now continues to fight against an extremely powerful undercurrent, a supposition, a shared belief that is a failed program and a public policy disaster. So that's what I got. We talk later.
Well, thank you. Ed used the term journalists as lab rats. I feel like the big rat. So this has been, for me, a very interesting couple of days. I want to thank you, Charles and Dan, for inviting me here and for analyzing a lot of the work that I do in your book. It's fascinating. I know that this has been a theoretical analysis of what we do because I kept a running list of words that I didn't know. And it was very, very long. Most of them ended in Asian, A-T-I-O-N, or there was a I-Z-I. There was Isications and lots of Asians. So I know it was a very serious discourse. So what I want to do is briefly tell you why I practice medical journalism, and I'll be brief on that. And then I want to show you just a clip of one of the stories I did. This will need to be. Oh, there. Okay, it'll come up. A 1-minute clip, which is about typical for what I get to do an in-depth analysis of a very important health issue. I came to medical journalism by accident. I never had any interest in journalism as a young child. I never felt that I wanted to grow up to be a television doctor. I came to this through my passion for public health. I'm a general pediatrician. I still see kids, but I view myself as a public health practitioner. And back in 2009, through very odd circumstances, I ended up being the acting director of the CDC when the swine flu pandemic hit. And I had been in charge of emergency preparedness and response at CDC for about 4 years, and had dealt with a lot of big bad things in public health. And there's certain things that you always do as part of your response to a new epidemic. And we were doing all those things. But I also put a lot of attention on communication. And as an agency, put a lot of attention, we all put a lot of attention on communication and communication through the media. We had all been trained in risk communication, and we'd learned the tenets of that and the importance of being first, being right, being credible. For that reason, we wanted to make sure that if there was any media outlet that wanted information, they could get it from us. So I held daily press conferences. In the morning, I was on all the news shows. In the evening, I was on the news shows. I used repetition. One of the speakers talked about the importance of repetition. Leo, that was in your talk. Well, we used repetition a lot. In these sessions, I went through the same thing. All of the rules of responding to a pandemic, that you have to hit it hard early until you know that you don't need to, then you can back off. We're going to be aggressive. There's going to be things that we don't know. We're going to tell you what we know, what we don't know, and what we're doing to get answers. And over, every day, I started with the same thing. I would start with that frame so people knew where we were coming from, and then I would say the facts. Okay, today there's this number of cases, or this number of that. Early on, it's like there have not been any deaths in the United States, thankfully, but unfortunately, I expect that in the future there will be. So principles of foreshadowing what was going to be coming. All of these components of risk communication I used in those briefings and whenever I was on the air. And we had polling that was being done by Harvard School of Public Health throughout this period. And what we saw was that people's knowledge of what to do to protect their health was going up and up. Their knowledge about staying home and covering coughs and washing their hands. But we also saw that their trust in government was incredibly high. It was it had been higher than it had ever been seen for a health crisis in the US. And so it gave me this sense that communication through the media could be an effective way to try and move public health forward. So when the permanent director of CDC came on board and I was looking at what I wanted to do next, I was thinking about academia. I had been at UC San Diego for 5 years on faculty. I thought about foundations or other branches of government. But I had been contacted by 2 television networks. And they said, you know, we really like the way you communicated on your press conferences. Would you be interested in being a network medical correspondent? And I thought that was very funny. I didn't watch our shows. This isn't being videoed, right? I know it is. So I didn't watch our shows. That's not where I got our information. But I knew that tens of millions of people did get their information there. And if the goal was to try and give people evidence-based information that people could use to either understand a problem in a different way, or to make better health decisions, or information for policymakers so that they could maybe see a problem in a different way, that I was being offered an incredible bully pulpit. And so I joined ABC News about, it's over 7 years ago. It's the longest I've had any job. But there I have a number of different roles. And I was trying to think of the different things that I do. I'm a screener of press releases because we get hundreds of press releases from drug companies, universities, everybody who wants to get something on the air. And we have a team of doctors who read through those, and we try and sort out what's good, what's not, what's important for our audience to know, what's good television, what would make a good segment, what do we think our competition might be covering. Those things all factor into what we do. I'm a translator, so I take complex medical information and try and do what I do when I'm in the office with a patient. As a pediatrician, I'm constantly translating. I'm translating to parents what's going on with their children. And I try and do it in a way that is respectful of the fact that the person I'm talking to doesn't have a background in medicine. And so I translate, and that's what I try and do in the air. I'm an educator, I'm a conveyor of information, I'm an advocate, and I don't hide that fact. When I'm presenting the results of a new study, there's where I want to keep it clean. Here's what the study showed, here's how it was done, here are the findings. But there's almost always that time where the anchor turns to me, so Rich, what do you think? And that's where I give my opinion. And that's a different hat. And it's usually a very short amount of time I have, but I'll say, my take is, the flu vaccine may not give you 100% protection, nowhere close, but it's the best thing you could do to reduce your chances of getting the flu. I don't say, well, the CDC recommends that everyone over the age of 6 months get the flu shot. And if you're between 6 and 9 months, you need 2 shots over the period of 6 months. No, I say, I think you should get the flu shot. And they hire me for my opinion. If all I would do is sit there and say, this is what this group recommends, they would have no interest in that. They want my opinion. They want me to be America's doctor. They want the viewer to connect with me at a level of trust, and that's what I do during that last period. I'm an epidemiologist as well. And so I trained at the CDC as a disease detective. I trained in field epidemiology. I've done a lot of research. And as an epidemiologist, I know that the truth comes from aggregating data, right? An individual is someone that you use to generate a hypothesis. And then you test that through different study means. And hopefully coming out of that, you'll identify a risk factor or something else. My first study, I identified apple cider as a vehicle transmitting E. coli infections in Massachusetts and causing kidney failure. I found that through aggregating data. In talking to people and hearing their stories, they implicated the Van de Kamp's fish sticks. Right? They said, my daughter had Van de Kamp's fish sticks, and the following week, she developed diarrhea and then kidney failure. And over they were saying Van de Kamp's fish sticks. And I even went, the first day out in the field investigating this, I took a camera and went into the supermarket, and I'm like photographing the Van de Kamp's fish sticks in the freezer cabinet. But when we did our study, what we found is that every child in this town in Massachusetts, between the certain ages of like 9 and 14, eats fish sticks, right? It's just what kids eat. They don't want fresh fish. They love fish sticks. They're breaded. They're fried. They taste good. You put ketchup on them. You don't know you're getting some fish. They love them, right? But I also learned that there's about 6 varieties of Van de Kamp's fish sticks. There's your whole fish sticks, your long fish sticks, your little fish nuggets, your this and that. And it washed out because everyone ate fish sticks. But what the parents didn't realize is that their kids had all consumed fresh pressed apple cider from one apple cider stand. And that I got just by going, listening and talking to people and then testing it in this. They also all ate sliced deli American cheese. So that wasn't it. But it was the aggregation of the data that showed me the truth. What I do now as a medical journalist is the exact opposite of what I did as an epidemiologist. I take a situation and I disaggregate it down to the individual, because data have no power in terms of motivating somebody. Saying, well, heart disease is the leading cause of death in men and women in America. Yawn. I say, let me introduce you to somebody. This woman, she is the person who holds her family together. And she's always doing for something else. And one day she had this feeling of upset stomach, unlike anything she had before, and she just put it off, and she put it off, and she put it off. She was having a heart attack. Right? So hearing about an individual experience and meeting her and letting her talk about that, because she'd then get a soundbite before you come to the doctor who tells you what to do to prevent heart disease. Hearing her story is what is compelling. So I want to show you a 1-minute video clip. This is because there's been so much discussion about the Ebola epidemic in 2014. When you all talking about that, I thought about this clip and the images that we selected here. The use of technology, of masks, it really it helped me view this clip and what we did in a very different way as I thought about the different constructs. But it was one of those stories that just, if I can find it. Here in the street of Monrovia, there's a body here. Maybe Ebola, maybe something else, but the burial team has come. They're busy spraying down the area where the person is. They're going to wrap in plastic and take away. But I was talking to someone in the community, and they had someone sick here yesterday. They didn't think it was Ebola. They thought it was something else, and they called for help. and no one came. They called again and no one came. And not until he died, a 37-year-old man, not until he died did they come. And then they called, and within 1 hour, the burial team is here. This is a place right now where if you die of Ebola, they're very quick for you. If you're living and you need help, there's really nowhere to go. He's not dead. He's not dead. They were wrapping him up to take him away, but he's alive. He's moving his arm. They almost took him away to the crematorium, and they noticed he's moving his arm. I don't know where they could take him. There are no hospitals to treat him. Now the first responders, the ambulance is here. They're trying to get them to stop to take him and to somewhere where he can get some care. Exactly. Yeah, but it's not clear yet whether are they here for him or they're driving by. They're going to take him. The problem that they have here is that there's a lot more room for dead bodies than there are for people who need treatment. So when they thought he had died, it was very easy to come and collect him. But now the ambulance is here, they have to find a bed. And beds for treating people with Ebola are very scarce here in Monrovia. So the crowd is not happy. They want him taken right now to somewhere where he can get care. It doesn't look to me like he's going to be able to make it. Very few signs of life. But for them, he's a member of the community and he needs every chance that they can give him. What I was trying to do there was to humanize the epidemic. I was one of the first TV journalists to go over there. Because I'm a medical epidemiologist, I was given access that other people weren't in terms of putting on suits and going into the wards and viewing the situation. But I also viewed myself in a big way as an advocate. So in telling the story that I came back, I wrote 2 opinion pieces for the Washington Post about the lack of international response, the lack of US resources going for the problem. Here, the purpose of that story was to indicate that there were no beds, there were no treatment beds, that not enough was being done. Interesting the way that story was received. There was people who felt that the U.S. should not be assisting. There was quite a lot of conspiracy stuff around that story. They said, well, clearly it was done with a green screen, that I wasn't there, that you could see me actually signaling for them to come in with the stretcher, that I cued them. If it was truly Ebola, there was no way I would be so close to someone with Ebola without a suit on. The kind of conspiracy stuff around it was pretty incredible. But I do feel that the coverage that we gave to the story, and that a lot of print journalists gave, the New York Times I thought did a terrific job, was very helpful in getting the Obama administration to commit to sending troops over to build treatment centers and to commit large amounts of money to the problem. So that's all I want to say. I really have appreciated over the past couple of days the different analyses of medical journalism and what it is, and I think it will help inform what I do as I think about the images that we choose and the relationship we have with the different creators of medical information as we try and report on it, because it is a very enmeshed relationship. Thank you very much.
For this session is thinking about the linkage between research and practice, from research to practice. So the overarching framework or possibility that I will offer for thinking about health communication is in terms of the notion of rights, right? And conceptualizing rights as health rights in terms of universalizing the right to health, and communicative right, universalizing the right to communication. Now the thing is, these two rights, I believe, in terms of the questions of both theorizing and practice, are intertwined, because the right to communication also then means the right to defining what is health and what constitutes health. And hopefully that expands our scope beyond just looking at medicalization, as you pointed out, Laurie, but also looking upstream at spaces we live in, our localities, our housing, our environment, the climate, the schools we have access to, issues of social class, issues of empire and imperialism, all of the various kinds of factors that constitute the broader rubric of health. But also communicative rights fundamentally raises the question of thinking about power, theorizing power, but again, coming back to the question of practice, how do we invert these inequities in distribution of power so that communities, individuals, families have opportunities of participating in these spaces. So in terms of how we think about health communication, the pedagogy of health communication as well as the research of health communication, one of the first things is, of course, behavior change, individual behavior are important, but the sort of determinism we have on behavior change limits us in terms of the kinds of things we see and we do not see. So moving away somewhat from the individual-based focus to looking at structures and the ways in which structures constitute health. This also then means that for the practice of health communication, these are interesting challenges. Again, I go back to your example, Laurie. Working in the inner city, there are times when I would see the act of, say, 5 fruits and vegetables campaign would be about creating ads and sending out pamphlets into the community without realizing what are the kinds of grocery stores that community members have access to and what is the price they have to pay to buy fruits and vegetables. So I think it's something as simple as that, but to think about structures fundamentally transforms the narrative, and that's where I find your work on health advocacy, particularly looking at policy context, really important. Also, once again, a similar kind of argument can be made about technology. Technology is important, but too often I'm struck by study after study that talk about Fitbits as interventions to health and that completely miss the forest and the big picture, right? So we have to also think about the ways in which technologies limit, particularly our abilities to imagine what other possibilities are enabled or could be created. So I think we also have to look for what possibilities could be. So looking at the Ebola context, for instance, the technological narrative you pointed out is one narrative, and I think that's a very powerful example you point out. And as I was asking you, the question then becomes what other narratives can we also see of communities coming together, creating infrastructures, developing solutions to treating that healthcare crisis. And I think it's important to open up that discursive space to those communicative possibilities. The third thing I would argue is thinking through narratives of securitization and militarization. So, I think about the post 9/11 context, and we talk about, the newspaper of record, and there were all these articles on bioterror that in some ways manufactured a threat of bioterror to articulate particular kinds of possibilities or to leverage particular kinds of possibilities as solutions. So as we think about this securitization narrative, we must also think about what are the consequences when we think about security as the frame. So what, for instance, when I think about the US PEPFAR initiatives, right? What are the consequences when HIV/AIDS response is hosted in military and under the Department of Defense? And I think there are broader ramifications for this that need to be articulated and thought through, and particularly both in terms of the symbolic, but also in terms of the material. Moving from this then, the question for health communication becomes one of defining health interventions as one that looks at health advocacy and health activism. Sort of then more broadly asking, what should the picture of health activism look like, particularly in terms of disrupting the ways in which communication circulates around health? So are there particular logics of flow in terms of how communication circulates? And what are the ways in which these logics of flow can be disrupted so that spaces can be created? Now, that's a major challenge because the ways in which communicative structures are situated within broader political economies, there are limitations in terms of who can participate and who can have a voice. So the real interesting question then for, I think, health communicators becomes one of how do you creatively develop and work through strategies that disrupt these kinds of fundamental inequities that are built into the ways in which these structures are organized. The other question then that builds on this is how do you imagine health? How do you create spaces for imagining health, create openings for other kinds of imagination that disrupt through silences and enable us to have conversations that we otherwise don't have because of our siloized, narrow viewpoints? So I will give you a few examples of this. So for instance, what does it mean when we think about health within the context of social movements and movements for social justice? What are the articulations of health in the context of Black Lives Matter? What are the articulations of health in the context of Standing Rock? What are the articulations of health when MSF hospitals are bombarded and particular propaganda machineries silence this bombarding of MSF hospitals? I think those kinds of inconvenient conversations, effects of war, violence on health need to be centered in how we think about communicating health, and particularly in terms of breaking through the kinds of propaganda we see in market-dominated frameworks driven by the empire. Which also brings me to my next point, which is that within the broader global landscape of health then, a worthwhile question to ask when we think about global health is how does empire shape the ways in which communication flows, what can flow, but what cannot flow? Right? So communication flows one way, but other kinds of articulations do not flow the other way back. So what are the roles of health activism and health justice in enabling these spaces of flowing back? So say, for instance, what happens when we start creating spaces for listening to voices of families that have lost children that have been bombarded in Afghanistan? What are the effects of the drone attacks in terms of the health context, and where are the spaces for listening to those voices? And again, I think that is about inverting the spaces and sites of communication. Finally, as I wrap up, I think when we think about this, one way of organizing this, at least that's how I think of it in my own health advocacy work at the Center for Culture-Centered Approach to Research and Evaluation, is in terms of thinking through how do we recraft narratives? How do we tell different kinds of stories? How do we reframe those stories? And then how do we train the next generation of health communication scholars, activists in thinking through the point of storytelling in different kinds of ways, and particularly thinking about creative strategies for social change that enable us to disrupt some of these mechanisms of power. Thank you.
One of the fathers who lost many of his children, thinking about the narratives about somehow all of a sudden there was a fever that no one had seen before, and then all of a sudden it grabs, in their words, another child just in the same sort of way, and thinking about a child dying, going to the clinic, having no diagnosis, then having the next child become ill. This woman lost all three of her children. This is an infant born after the time. So here's the healer to whom they took the child, the local nurse, actually with a physician, Dr. Claudia Montini Briggs, standing behind there. She's not always in the local clinic. And here's the local clinic with in the physician. So they took them to the Metropolitan, to the hospital in the state capital in Tucupita, where they said we have no idea what's going on, and sent them along to the clinics in major metropolitan centers where the children all died in the ICU. Epidemiologists came to study. Teams and teams of epidemiologists came to Mucuboina. They asked questions, they collected data. These are very good, accurate data collected by Cuban epidemiologists in the very early days of the epidemic. And yet, it was a year before there was any idea what might be killing the children. At that time, according to what we can see, 37 children and young adults had died. Now, the first thing that this story might be about is health disparities or health inequalities. There was a lack of access to care. That's often the standard line. I won't talk about some of my wonderful colleagues in medicine and anthropology for whom that's a major message, and that often is an important story. But not here. This was in the middle of President Chavez's revolution. And one of the parts of the revolution was to bring health care to the 60% of Venezuelans living in poverty. Right? The children actually were covered by, this is, you can't see it very well here, but this is in the middle of a barrio, a poor community, where an article from the Constitution that guarantees health as a fundamental social right, guaranteed by the state, is written on the wall of this barrio. So thinking about this, and that was the context in which this occurred. So access to care. All the children got treated. No one got a bill. No one was turned away at the doors of the hospital, unlike in some other countries we might know. So what's the problem? It's not my identification, because I want to tell you this is not research. Dr. Claudia Briggs and I were there by accident when this epidemic was unfolding and asked to be able by the residents to participate. Here is what they said. So here's the president of the local health committee around the clinic. And the parents kept saying, all of our children are dying, we don't know why, and we want you to push the officials in the health in the city to tell us what's going on. So they went and went and went, and there was still no diagnosis, no solution, no way of stopping the epidemic. So he showed up with some of the parents in the state capitol and went to the legislature. And they held an open meeting where all of a sudden epidemiology became the focus of public debate. And here's a very rare image, which you can't see too well right now, but there's Conrado Moraleda there as framed as an indigenous person in a public context with papers in his hand presenting epidemiological figures that he himself had produced. So, and here you have the legislature declaring an outbreak of an infectious disease in the lower delta. So the response largely from public health officials, now this was in the second wave of this epidemic, was that they were extremely angry. They spread rumors around the town and over the radio, suggesting that really the problem was that it was indigenous parents who were killing their own children by feeding them garbage or poisoned fruit or fish, or that maybe it was the indigenous healers who were killing their own patients. And then they would actually come out in other statements to the press and say, well, really we believe in these healers, it's not them, but maybe it's the fruit. So this became an issue that was really, can you imagine that? You've lost all of your children to a disease, and then someone brings a copy of this newspaper back from the city, and you find that you're being blamed for their deaths. So they framed this differently, as not being about health inequities themselves, but about communicative dimensions. So what did they face? So the parents, what were they doing? They were sitting there taking care of these children, one another, often spending, putting themselves into debt for years to buy the gasoline and the oil and the use of a motorboat to be able to transport their children. They were also, at the same time, looking around them and asking questions. They were listening to other parents, trying to create an archive of knowledge because they wanted to figure out what was going on. And they saw their encounters with doctors and epidemiologists as the possibility of dialogue. How might we together come up over the course of a year now? What's going wrong and how can we help? And so there was a stacking of, this is what we've done to be able to help save our child, our other child. And this is what people have told us. This is what we have observed. And what happens? So in the clinic, essentially, in the local clinic, parents are asked very focused questions that are focused on the symptoms themselves. Their narratives, this archive, was not really allowed into the clinic. Right? What happens when they go to healers? The healers who spoke their own language, the indigenous language, of course would listen to their stories. Absolutely not. They considered them to lack the proper knowledge of how to turn details into diagnostically relevant information, and they didn't let them tell their stories either. The healers were just as much involved in what we might call health communicative inequities as were the doctors. Their experience in metropolitan hospitals, the higher the level of care, the less space was available for the parents, so that when they arrived in the city, no one even asked them questions. They just looked at the one-page referral sheet that was provided by the doctor back in the rural clinic. So here, then the parents brought back their children from the city, they opened the coffins that had been provided, and they found that autopsies had been performed. No consent, no explanation, no conveying of the results of those autopsies. And that was the moment at which things really began to fall apart. When the epidemiologist came, the parents said, finally, someone wants to know what's going on. They've come to our community. We'll tell them what our observations are and tell them what it meant to us to lose our children. And the epidemiologist said, oh, we don't have time to listen to your stories. We want to know, remember the data sheet I showed you? The name of the child, the date of birth, the date of the onset of symptoms, the date of death. Right? And that's all. They made observations, and then the parents said, all right, before you leave, tell us what you know. But the epidemiologist left. So asking for this lateral exchange of knowledge failed. The parents went to the city and said, this is a public health crisis, and we want to contribute with you in thinking about what might be going on. The response by public health officials, who were genuinely concerned about the epidemic, there are no villains here, folks, was negative along those lines. So here, in terms of health communication, when the epidemiologists came, they often said, we will teach you about essentially hygiene, right? Stereotypes of the indigenous people as not understanding hygiene. The same old linear hypodermic injection of knowledge for people who are trying to say, we know something. Let us tell you what we know and see how that might be valuable. And then, in terms of news coverage. So there were brief, interesting news reports, as the one of Conrado Moraleda, saying, here's an indigenous man presenting knowledge about health. And then immediately the other news coverage became negative. So what did people do? They said, we're stereotyped as being too stupid to understand what doctors tell us, but we're going to become the producers of knowledge about this epidemic because we want to know how to save our children. So then this individual, Enrique Moraleda, Conrado's brother, joined with his brother and said, we're going to organize our own investigatory team to figure out what this disease is. They brought on board Tirso Gomez, who unfortunately now is no longer with us, who's a healer, an indigenous nurse, an EMT, Norbeles Gomez, a physician, Dr. Claudia Briggs, and then a humble anthropologist and photographer. And when we went to all these communities and said, all right, and they said, we want to tell you our narratives. So we organized these meetings where there would be space for their narratives, for epidemiology, for clinical medicine. And so people said, this is what happened. Well, guess what? For a good clinician like Dr. Clara, we got the same story. Begins with headache and fever, and then their generalized pain and body aches. There can sometimes be stomach aches. There was a strange itching or burning in the extremities, which became numbness and paralysis, agitation, hypersensitivity to touch, insomnia, strange neurological disorders, and then difficulty first swallowing food and then water, and then hydrophobia. Now, probably most of you have figured out what's going on there. Then excessive salivation, followed by death in every single case. Right? So clinically, Dr. Claudia was able to identify this as being rabies. The observations produced by the parents suggested that the children, most of them, that died had been bitten by vampire bats nocturnally from 1 to 2 months before the onset of symptoms. Right? So actually there are often lots of bites from bats that are not detected, so they didn't reveal this for all cases, but that's quite normal. So then there was this sense, the indigenous folks said, the team said, we are going to produce our own report and we're going to take this information now to the national, we're going to take this to Chavez. We're going to take this to national authorities who have demonstrated their own commitment to indigenous health and to the health of the poor. And also to the national and international press because we want to tell our own story about health. And here they are in the National Reference newspaper, and if you can't see too well, when shown to the photographer, they pulled out the photographs I had taken of a young woman who was dying from rabies and said, these are the people. We want the people and their voices to remain a part of the story that we're telling. All right, so what can they teach us? What does this say about now, in some sense, the translation of research to practice? By the way, you should note that this wasn't research. This was actually learning that emerged through practice. We're kind of moving in the other direction here. What can they teach us? First of all, the parents experienced health communicative inequities at every site. Why have something so awkward as health with a big diagonal and communication? That's been my pitch, at least all the way through these 2 days, is that when you separate those two terms, the game is over. Right? So somehow we were looking at how it was that this health crisis was also a communicative crisis about not respecting rights about health, which resulted in the lack, which helped to promote the lack of a diagnosis for a year. Healthcare came to be perceived by parents through the lens of health communicative inequities. The autopsies with no consent and no explanation embittered parents, and they came to think about the health that their children received in ICUs as torture. Somehow that way in which their own efforts to communicate about health and how those were treated and how their patients were treated were one. And that became the focus of their own organizing. So this revealed how those health disparities or inequities are themselves deeply connected to communicative health inequities. They are the ones, through their own bitter experience, who said it's not just that all my children died, it's how we were treated and how our own efforts to be able to save them themselves were denigrated throughout. The parents and local leaders always, through this effort that they made, said, we want to stop the disease, we want to figure out what's going on, but we want to challenge these inequities. We want to challenge the way that we get treated through all of these different spaces, and we want to make a contribution to global health. We have, right, get rid of the idea that the subaltern has specific practical knowledge that professionals need to generalize so that then it can be turned into policy or scholarship. Their goal from the beginning was to contribute to larger debates about global health. So what else can they... So is this just Venezuela? Is this just one case? I don't think so. Give me another hour, I'll tell you a little bit more about why I don't think so, but let's go back to 2002 when the CDC came out with a report that was shocking, that Latinos and African Americans have worse health outcomes in the United States. Then 3 months later, the Institute of Medicine says that Latinos and African Americans receive poor health care than other groups after controlling for socioeconomic status and health insurance. And one of the factors they identified was the stereotypes that clinicians sometimes make of their patients on a racial basis as communicators in terms of what they think will be their ability to understand what the doctor says, to be able to turn that into behavioral outcomes, right? Mind you, not knowing the patient, but on the basis of the racial classification of the patient. In other words, that here, what we would see as being a health communicative inequity as affecting clinical care. So that's clinical care, great. What about also doctor-patient interaction or communication? It's been a major focus of medical education, but it's largely been seen as an issue of we need to change the outcome. We need a technological fix. We're going to train doctors to listen better to their patients. Some have actually said we need to train patients to listen better to their doctors. That's not necessarily bad. But what the parents were suggesting to us is if you start with communicative justice in health as the goal, the question of how doctors and patients might interact becomes quite different. Health communication. So here if we see the linear hypodermic model of health education, right, which unfortunately has not entirely disappeared as a fundamental violation of health communicative rights, as instantiating health inequity, as erasing, as constructing a model of the person who's supposed to receive the information. Guess what? First of all, it's an issue of social justice as well. And second of all, it dooms health education to failure. And I think that Mohan's wonderful presentation suggests if I have to accept an image of myself as stupid and incapable of learning in order to be able to be interpreted, to listen to that message, guess what? I might be somewhat less motivated to be able to somehow feel as if I'm included and to use that information. Epidemiology is also part of health communicative inequities, as beautifully shown by the parents in their very angry responses to the epidemiologists who they first embraced. And so therefore, who counts? who gets to fashion the categories that result in the counting, and who gets to interpret and to report the counting, is also part of the larger issue of what I would call health communicative injustice. What about policy? One thing that did happen that was wonderful in the early days of the revolution was that health policies were enacted, were planned in the spaces to which they were applied. In the poorest communities in the country, planners and community workers and researchers came together to say, what can we do? And have a lateral knowledge transfer. So that here, questions of health communicative equity become part itself of the generation of health policies. So, and then the media, right? So we have to think about this, I would suggest, about the content of media, images and text, and I think that Leo's presentation was an incredibly interesting wake-up call along these lines. But also models of communication. If the projection within a news story, regardless of the content, is we're medical authorities, we have knowledge, you are lay people, you have no knowledge or you have mistaken knowledge, and the only way, and we are going to therefore replace, we're going to fill you, replace that model. That's the role in which you could play. That's, I should say, or a second model that says you're an active patient consumer. You get to get information from all over, and then you have the right to consume any health services that you might like. By the way, guess what? So the first model applies is the one that ordinarily appears in stories that focus on racialized populations. Right? So African Americans and Latinos, when they enter into news stories, are primarily in this very now dispreferred position of just sitting there and getting the information and essentially not having any active role in assimilating it. As opposed to ordinarily when you have a picture, and I do mean a picture, right, often of the active patient consumer, that more often tends to be a person not identified as African American or Latino. And in general, most of us, as laypersons, are seen as not capable of producing any valuable knowledge in health. And frankly, I think that's a major problem with respect to all of these. So, all right, we've got all these different sites. So what? The health community inequities are the glue that tie these different sites together. The parents kept saying that all over. Here I am in the clinic. Here I am in a Metropolitan hospital. This is what they're saying about us in the newspaper. And seeing the relationship of stigmatization and of the erasure of their knowledge and their efforts to contribute to care in all of those sites. This is what? Those are all different sites. We don't even usually think about those together. That's kind of partly why Dan and I have wondered about this issue of biomediatization, of being able to connect those. And that's what they were doing. And so let's see, skip ahead here. So what might we think about this? Now, I'm a little worried about universalizing notions of communicative justice and health because, frankly, I don't know that anybody gave me that particular position. I think those should be discussions that are carried on in each site that respond to some of the forms of inequities and also the possibilities, the discussions. That's all of us should be involved in this. But if I were to give some basic principles, one might say as issues of justice, no one should have their contributions to care or to knowledge about health erased or pathologized. What counts as knowledge relevant to shaping health policies and practices should not have any one sector, whether it's health professionals or anyone else, should be seen as the only people charged with producing knowledge about health. An individual's classification in terms of gender and sexual orientation, race or class, or professional standing should never provide grounds for dismissing, right, one's possible contributions to knowledge about health and defining populations as failures in advance, as being out of the loop, as being incapable of even understanding what biomedical professionals say is one of the most fundamental dimensions of shaping understandings of inequality in society today. So here's my policy recommendation, all right? If you look at the Venezuelan Constitution, it guaranteed health as a fundamental right guaranteed by the state. That's great. But guess what? No one ever thought about health communicative inequities. These things came up through these organically, through many of these discussions, but even the Cuban epidemiologists and Cuban physicians who brought healthcare to communities often lost those as the great contribution to thinking about global health that came out of that particular program. So let's go back, as Lori mentioned, the WHO Constitution, 1948, with health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And the idea that there is a fundamental right of every human being, without distinction, to health. Not amended since 1948. So my simple proposal is, maybe it's time to amend the Constitution. Thank you very much.
Okay, I'm supposed to be the last speaker, but I think that Charles, in his very eloquent presentation, went a bit over the 10 minutes. So I'm going to try and make some very brief and kind of informal observations adding to some of these things, and so we can have a little bit of our discussion here. One thing to elaborate on just a little bit here is that I think that one of the most interesting and also difficult questions in health journalism, and to some extent more generally health communication, is about what is the right way to handle the question of communicative authority. That is, who has the right to speak about issues of health. Health is a kind of special area because it is a realm in which esoteric specialized knowledge has a privileged place. And in general, the journalists who we interviewed were very strong advocates for the idea of evidence-based knowledge, that is to say, knowledge that is based on systematic biomedical science. And that's a good thing in many contexts, right? So a lot of the kinds of discourses, for example, that Leo Chavez was showing us earlier today about the danger posed by migrants, the need to close borders, and so on, that circulated on the right-wing websites, those were generally excluded in most of the cases he cited from the mainstream media because the journalists were, in fact, relying on the scientific evidence that those kinds of measures were not productive, and that's a good thing. On the other hand, as Charles and Mohan have said, there are many kinds of voices and many kinds of knowledge about health that need to circulate in the public sphere. And certainly a discourse that is exclusively based on transmitting knowledge produced in the realm of biomedical science by specialists to lay publics is not what we want as a form of health communication. And so how to think about who has the right to speak about what in what context, I think, is one of the most difficult issues. I also want to say something about the question of how the conversation can be rebalanced to give more attention to the kinds of social context and social factors that Lori and others were pointing to. Michael Schudson, in his remarks earlier today, noted that in our study we did this content analysis and we were coding the stories for whether they were employing a biomedical frame, talking about, basically physiological intervention using medical technology, a lifestyle frame focusing on individual lifestyle choices, or a social frame. And we showed that it's complex. That contrary to some accounts, it's not correct that it's all a biomedical framing. But I would say that I think in the view of both of us, there ought to be a lot more attention actually to social factors. And there is definitely a tendency in journalism to move to the question, many stories that would start out looking like they might have a social frame, but they'd finally move around to the question of what can you do about it? That is, you, the individual. And they would move away from the kind of social understanding of health that Lori was talking about, not to ask the question, what can we do about this health problem? And I think that's a general issue in both health journalism and health communication more broadly. One final thing I'll add here, and maybe I'll stop with this now, is about the Affordable Care Act. We have some discussion in the book about coverage of the Affordable Care Act when it was initially debated and actually had to cut out, because our publisher thought the book was too long, a much more elaborate discussion of that. But I would say that the greatest problem with the coverage of the Affordable Care Act is that it was all completely taken over by the political reporters, and it followed what we call in political communication the game frame. That is to say, it was all about counting the votes and the question of whether Obama would get the plan through, whether it would hurt his popularity, and there was almost no coverage whatsoever of the actual substance of the policy and the social problems to which it was addressed. The health and medical reporters were almost entirely sidelined in that coverage, and I think it is a kind of key question going forward here with our new set of discussions about health policy, whether this aspect of the social context of communication gets covered in a serious way, or we go back to the same kind of coverage of, the political game. So I'll stop and we'll open up for discussion.
I have a comment I want to make before. Before the comments, I want to react a little bit, Charles, to your presentation, because as an epidemiologist, I think I want to push back on some of your characterizations of epidemiology, because the example that you put forward of epidemiology, I would say, is an example of really bad epidemiology. Yeah. And epidemiology as a science starts by listening, and it starts by interviewing extensively people who are affected by an event. And if you don't start there, if you start with the data table, you're a crappy epidemiologist, and you're never going to figure out what's going on. But if you start by listening, the example I gave of the apple cider, I spent probably 6 hours with each family. And in addition to getting the story about the fish sticks, they told me about going to birthday parties and having apple cider, and going and visiting a farm stand, and a school trip where they went, a school trip with the orchestra where there was apple cider. And so they had the makings of it. And good epidemiology starts with that listening, but then it's empirical. Then you end up with a number of hypotheses that you test to see whether there's anything there. And in the example you used, where the family is with a clinical scenario, for an epidemiologist not to look at those symptoms and say, well, rabies has got to be on the list, so we'll make sure as we're doing this evaluation we are testing these children, these families, for rabies. We're catching bats and we're testing them for rabies. It just was a description of a really, really bad public health science. And I want to push back, because I think that my takeaway in terms of research to practice is, in practice, you need to make sure that you're including what everyone's been talking about here, about capturing stories from the community and listening, and not coming in with a preconceived notion from outside that you've got the solution that you're going to give. And it's a very collaborative experience when it's done well. So I just wanted to, as the epidemiologist in the room, just lay that out there.
Could I just add on to that? Because this gentleman had a question that follows right along with that. Rabies is hardly an unknown disease. How is it that no one had a light in their head?
Yeah, was no one tested for that?
No.
Ever?
No.
Then I would push back that it may have been rabies, but that's not confirmed, because those symptoms, while consistent with rabies, are also consistent with a number of toxins. And so, yeah, it was a if they didn't test anyone for rabies, they should have, because it's not that hard a diagnosis to make.
No, it's interesting. I was at the World Rabies Congress. They invited me, and I kept saying, I'm an anthropologist, I'm not a doctor, so we know it's okay. And over in the papers that were presented there, about 60% of the cases were not diagnosed as rabies. Mm-hmm. So it turns out that often it's a misdiagnosed disease. But here, I think that one thing that is And Dr. Claudia Martinez always presented this as clinically identified presumptive rabies.
Yeah.
So the idea was to ask the national government to conduct its own investigation. Unfortunately, what they did was they gathered about a dozen bats in one place that weren't actually even vampire bats, right? A very bad sample, tested them, and said there's no rabies. But in terms of thinking about epidemiology, the basic point is I don't want to isolate epidemiologists. And frankly, these were not, the Cubans also particularly were not bad epidemiologists. They started with a tremendous racial disparity between people classified as indigenous and people classified as non-indigenous, as Spanish speakers. And frankly, the Cubans were really sensitive to social class and really tone deaf to racism. Yeah. Right? And they reproduced that, so therefore, that's part of why I doubt if they would do that in other communities. So you see the same sorts of health community inequities that move through these different sites. And of course, these folks were in dialogue. They're also physicians. They're also working for the public health service. So I think it wasn't just that they were bad, but you get the resonance that occurs through these health community inequities through these different sites, and that comes to be able to infect, as it were, even the epidemiology, but not in all contexts, because that's why I say that is one case, and I don't mean to generalize at all whatsoever to all epidemiologists. It was not at all very much different than other sorts of epidemiological investigations in the country. So thanks.
Oh, I didn't realize there was one of these. Thanks for this really stimulating panel. I have a ton of questions, and I just want to build on the conversation that has already started. When you both were talking about the story about rabies in Venezuela and the parents with their assumptions about fish sticks, what came to my mind was how you framed the stories was very different. Yours was a story, Charles, about how the parents were right. Yours initially, Rich, was about how the parents were wrong. Yeah. Everybody thought it was fish sticks. And ultimately, just now, you said the parents had the knowledge that it was in talking and listening to them. But this story about the need for health communicative justice kind of raises questions about the role of the expert and the place for scientific expertise in health practice. I think there's so many historical examples, a ton from epidemiology, the history of epidemiology, and also clinical care generally, where listening to patients produce new knowledge about, say, the cause of cholera, the outcomes of rubella infection for women, the risks of the birth control pill, the list goes on and on. But the other story that I was reminded of when you were sharing the story about these parents in Venezuela, Charles, was that of parents today in the US of children with autism, and their belief that they have knowledge about the epidemic that is either not being heard or not being acted on by clinical and scientific professionals. So I think that I'm kind of curious as to where we go once we have health communicative justice. What does that do to the on-the-ground relationship between practitioners, experts, and lay people?
I mean, that's a great question. The question of autism and what's going on is, in pediatrics, one of those profound questions where we don't have the answers that people want and everyone needs. And in the absence of knowing what are the causes of autism and being able to show that scientifically, it creates, it's a situation where there's a lot of distrust and skepticism and fear, and that's not good for anyone. I've done a lot of reporting on autism. There are some in the autism community who feel very strongly that vaccines are linked to their children's condition. And there are others in the autism community who feel as strongly that it has absolutely nothing to do with vaccines, and that's a distraction from doing the research that they feel can really address these questions. But it is one of there are a number of different areas, but that's the one in pediatrics where there's continual distrust. And I hope through the investment in science that's looking at all kinds of factors, genetics, environmental interactions, will shine some light on that and answer some of the questions. But I think that if you stop listening to parents and getting ideas as to what could be going on, and you don't test those should be some of the hypotheses you're testing. I think when it comes to vaccine and autism, that was the case, and it's been tested over and over again. But until there are better answers, that's not going to be sufficient for anyone who has an affected child.
So hopefully my last remark here, because I've already had too much time, but first of all, the parents weren't right about content. They didn't raise the issue of rabies. They'd never heard of it. There had been no rabies epidemic, right? No rabies. It's no dry land. There were no dogs running around biting people. And also, so the pardon, it's not just about content, right? It's the question of how it is that we think about what knowledge is in health. Who has knowledge? Who makes it? How it travels? Is it only one way, right? It's that way of being able to say, your input is potentially valuable. I mean, in the work that we did, there was room for epidemiology in these meetings. There was room for clinical medicine, for examining the patient. And there was also room for people to be able to do testimonials, to express their experience about what had happened with their kids. And we got a ton of epidemiological information. Does that mean that there's no role for epidemiology? Epidemiology is very complex stuff, as those of you who are epidemiologists know, and I don't pretend to do it. So that doesn't mean that this is a leveling. It means an exchange of knowledge, and to think about, right to be involved in the exchange of knowledge, and to not be stigmatized for the role that you're assigned in that process is what's fundamental. The content is a little bit more tricky, because after all, there are no two diseases that are alike, there are no two cases that are alike, there are no two places that are alike, and that stuff is very complex.
Yeah, Leo.
I had just a quick question. It's kind of similar along these lines. There was a story a few years ago in California about cancer clusters among farm worker kids. I think it's probably leukemia, and they were convinced in their knowledge that it had to do with their local environment, the pesticides, the chemicals, and the news stories were pretty heartwarming. Gave a lot of room to the narratives. And then the epidemiologists came in and they tried to show if this happened or not. But the problem is epidemiology needs a lot of cases. And so there was sort of a conflict between the sentiments and the actual knowledge that these parents had that they were convinced their kids were getting cancer because of the environment. But epidemiology couldn't show it because of the amount of numbers that are needed to actually prove the relationship. So I think sometimes in the way a lot of things get presented in the press, it's not clear sometimes the epidemiologists look like they're bad guys because it's just hard for them to actually come to conclusions given the lack of data that they can put together, it seems like.
We found actually a lot of those stories. That was an interesting thing to us. And those were the stories where the journalists were obviously having trouble figuring out how to handle this story right. And they wanted to give the parents a hearing, but they wanted to, let science make the decision in the end. And there were often really interesting arcs that the story would go through over the course of the journalist interacting with organized parents.
Yeah, cancer clusters are probably one of my least favorite stories to have to relate to because they are so challenging. They're challenging because by chance you expect across country a certain amount of occurrence within a certain place and time. And it's very difficult because the experience of people who are undergoing a disease like cancer is to be much more aware of others with that condition around them. And so there's a lot written about pseudoclusters versus real clusters and how do you sort that out? There are a lot of things that can look like a cluster that aren't. But you're right, numbers can be a real challenge. Dan Fagan at NYU wrote a terrific book, Tom's River, that I think won a Pulitzer last year. But he looked at the whole issue of cancer clusters in New Jersey and how long it took for them to be able to identify that there truly was a major problem with water contamination. Because all kinds of different factors, political factors that were involved in a big way, but it's a great look at that issue.
I just wanted to weigh in, as kind of reflecting on the notion of communicative justice and trying to bring that into the world that journalists inhabit. And it seems to me that the fascinating case about the children dying of rabies, the reality that journalists are confronting now isn't one of of disenfranchisement. It's almost in a sense of kind of promiscuous enfranchisement of people who speak without authority and without direct knowledge. And that the world of what had been at one time authorized knowers, where you had a fairly confined population of people you would go to and reporting out a story, and you could trust that they spoke with some authority, and if they were speaking, and you could then go with that, and that would be the received wisdom. That has now given way to a time when everybody has communicative capabilities to weigh in and to rally support behind propositions that may be totally false. And the problem that journalists are having now is determining where authority resides, particularly in an area where specialized knowledge is important. And this is an interesting reminder that the normal repositories of specialized knowledge, normal repositories of authority, may not be worthy of trust. But it doesn't change the overall, if you pull the camera back, the overall problem of journalists is sorting through people who are now able to speak with a great deal of volume, a great deal of and velocity of messages, and can drown out information that's worth a good deal more. And it's sorting out the bad information because it's so much more available and so much more clamorous than ever. That is the bigger problem I think the journalists face.
Thank you very much for a wonderful panel. I had a question about, so in the United States, sometimes a medical diagnosis becomes a political category. Especially with autism, you have not only the parents, but the autistic people themselves who claim a certain kind of disability rights identity and a right to sort of claim, neurodivergence and a natural variation in human cognition. And so I'm wondering if you could reflect, anyone, on finding the right way of presenting identities which could be framed as medicalized or could be framed as politicized. So I'm thinking in terms of, the deaf community, I'm thinking in terms of different kinds of disability rights advocates that really frame the question in terms of political identities that then can leverage power to get access for everyone versus a medicalized identity that's waiting for some kind of savior to intervene.
I don't know about that. I don't have an answer, but I'll tell you what it made me think of. When you said autism, but I immediately thought of HIV. So I came up in San Francisco in the late 70s, mid 80s, and was working in the middle of the Castro at a restaurant, working my way through school and down the street from the Kaposi Sarcoma Foundation. And that was the precursor to the San Francisco AIDS Foundation. And there was a unique form of activism that happened at that time where the community organizing was organic because men were going door to door because they didn't know what they were dying from either. It's maybe a different version of the kids with rabies and their parents. And it was a really interesting, momentous convergence of identity and health and communication. So you had a real battle between medical establishment in San Francisco and in the nation. You had activists at ACT UP. You had the health department. You had the activists that could shut down the Golden Gate Bridge the way Black Lives Matter have shut down the freeway over here. And in the middle, you had the San Francisco AIDS Foundation. And in some ways, they were the negotiator. And it was political because they were trying to change what government was doing, and the ACT UP could pull the center because they were making demands that were way over here, and the health department could go to the San Francisco AIDS Foundation, and the AIDS Foundation could kind of be a negotiator and change that. But ACT UP was really instrumental in pulling that center. And then it was interesting looking at it through the lens of communication, because it was a long time before what was happening in San Francisco made it into the national headlines. President Reagan didn't say the word AIDS until Rock Hudson died. Magic Johnson revealing his HIV status was monumental. It was at the CDC where they got the most phone calls ever, was after Magic Johnson revealed that. And then the politics of AIDS was propelled in part by the fact that you had a whole community of gay men, essentially, some women, but mostly, we didn't even say LGBTQ then, it was just, but they were activists, and they were wealthier, and they were white. And they were able to marshal that to politicize what was going on with HIV. But it wasn't really in the United States and the country as a whole until Ryan White, who was a hemophiliac victim, was propelled as the symbol, and it was the Ryan White Act that got the federal money down into the states. So you had a lot of nexus between the health, the communications, and the politics all at once. And I have no idea whether that answers your question, but that's what you made me think of.
His microphone.
Well, what I wanted to say is, in defense of those epidemiologists, it's not that they are bad and you're good, or the other people are more or less, It's what the health report in 1992 said, that are stereotypes that are shaping our health services of healthcare system. And one thing is important is, yes, they did laboratory tests for some contamination, lead, mercury, etc., and that was ruled out. But I wanted to say that, unfortunately, some epidemiologists portray things like this kind of tables that doesn't speak too much about the relation of the communication with the patient. You did, and it's a good thing, but many people doesn't that. Like Mohan is telling, there is a vertical, every people in communication in health is doing really vertical imposing things and cut the communication with the patient. You have to do this. This is the way that you have to act. And if you don't do well, but like you are a bad citizen or whatever, or you are subaltern, or you don't deserve it, or like some people said this morning, you form a group that can be sacrificed, You don't have a choice. You will be sacrificed because you will die because it's an epidemic created or no. That is what we are talking about in this book, and that's why Charles Philippe, my partners in crime, like he said, is telling about this as story. People frame others people. Something basic, like you go to emergency care here, and I see that for the first hand, and the nurse who will take a vein can be Latino, can be Asian or black, well, usually not black, but Latino, and they said, I cannot take the vein because those kind of person have a spaghetti vein. What does that mean? It's stigmatization, and they got this as a knowledge, and they defend their career, their disciplinary engagement, but they don't go to the bottom of those problems. Say, why is this? This person is this person or is me that doesn't have the ability to get the vein? I don't know if I give you an answer, but the question here is not bad or good epidemiologists. It's people that are alienated for those stigma or those stereotypes, that is making the health fail. Thank you.
Yeah.
So this is a question for Edward Wasserman. I'm wondering about this name shift from the Affordable Care Act to Obamacare. And according to my memories, it happened incredibly fast, and not only in the right-wing media, but very quickly in the left-leaning media as well. So how do you account for that very quick shift, relatively regardless of ideological spectrum, while we all know that two important things got lost there, namely two words, affordable and care, which would have been incredibly important in communicating that act in the long run?
That's a great question. I can only assume that it was focus grouped out and the opposition to it determined early on that would work as a term of disparagement. And by personalizing it and associating with somebody they were very determined to discredit, they hope to score points from it. But you're right, losing the words affordable and care were I think, very damaging to the cause. Obama's subsequent embrace of it, I thought was, at that point it might have become inevitable because the headline writers had already gone ahead with Obamacare. It sort of passed into popular parlance. And maybe to some degree the disparagement element was reduced. But I thought it was a mistake politically for him to do that. Because then as his fortunes rose and fell and as he was continually to be targeted as a terrible president and all the rest of it, the law as well suffered. So,
Doug, the comedian Jimmy Kimmel did a terrific on-the-street piece about that, where he went to people on the street and said, so which do you think is better, the Affordable Care Act or Obamacare? And it was, oh, the Affordable Care Act is much better. And he'd ask the others, well, do you think Obamacare should be repealed and should be replaced by the Affordable Care Act? Absolutely.
Polls show,
it was incredible.
there was a poll recently that shows that there's a fairly significant part of the population that doesn't know that they're the same, right? Yes.
So I have a question that I'm going to try to weave in a lot of remarks that were made because I kept thinking about this one thing throughout the whole presentation, which was around climate change, which of course is a true public health emergency, a crisis in my opinion. So the first thing was about the difference between social justice and market justice, and it made me think of George Lakoff's framing around with the market justice being kind of the strict father model. Are you familiar with George Lakoff's work? Any of you, or not? Someone not familiar? So politically, he sort of talks about that Republicans in particular, or conservatives, have a view of sort of a strict father, more authoritarian frame, and liberals, Democrats have a more nurturing mother type of view, and that colors information that they hear. It colors everything and how they view things. And I think you could see how that might work in various contexts, in particular around just health issues, of course, and any kind of policy issues. Secondly, I thought the listing of the things that the media was covering instead of the Affordable Care Act, I think it was, and how it ran afoul of these strong ideological currents. And I think it was Mr. Wasserman mentioned, government incompetence, the loss of personal choice, so on. All of those could be applied, I thought, to climate change. And I guess I was just wondering how you could talk about that particular public health issue in the context of some of what you've already been talking about, in particular, sort of, if you had advice to give to the folks who are fighting climate change, what would you say?
Well, I can speak a little bit to George's rubric about strict father and nurturant parent. George's idea is that it's a moral underpinning. So what motivated him to come to that analysis was when he was watching debates and Dan Quayle was in some debate, and it was and there was this juxtaposition he couldn't understand. It was that the same people who were against abortion were for capital punishment. And that just didn't make sense to him. How could both of those things be true? And what he kind of puzzled through and looked at a lot of language, I assume, to arrive at this fact was that it was they're both moral positions, strict father and nurturant parent. And the strict father idea does line up with market justice. It's the metaphor of nation and family, and the father's the head of the family. And the moral part of it has to do with the way you think the world works. And if you think the world is a dangerous place in this rubric, then you need to be equipped to withstand that danger, which means that you have to prepare your children for that rough world. And so the metaphor between strict father and nurturant parent is about when the baby's crying in the crib, do you pick it up? That's the central question. And if you're a strict father, it would be immoral to pick up that baby, because it means that you would be coddling that baby and not preparing that baby for the life ahead of it. And it will fail, and it will lose, and it will not succeed. And so you need to start now, and you let that baby cry itself to sleep. And if you are a nurturant parent, you have a different moral structure, and your moral structure is that when the baby cries, you pick it up, because you want that baby to know it is connected, it's part of a community, and it's a communitarian moral system that protects us and will prepare that child and will make sure that child knows it has an obligation to the collective good and to others, and that's what is important in that moral structure. And so, you know, Jared Bernstein, an economist, kind of talks about a very similar thing. He talks about yo-yos and wits. Yo-yos are you're on your own, and it's the same moral structure, and wits are we're in this together. And it seems to me that climate change is really about helping people understand we're in this together and making the invisible visible in terms of those connections. We have such a strong, rugged individualism that runs through American society that it obliterates the connections we have to one another. And these things are both true. And they both coexist, and they can coexist in the same person. But we have a default frame that sends us to individualism, that lets us believe that we're on our own, that if we just have the right medical information, we can take care of ourselves, when in fact, we need not only doctors, but each other. And we need a community that can speak up and has the power to change the conditions in which health is fostered or diminished. And so that's the direction that I would go with it.
If I could just jump in. The implication of the analysis that I tried to offer was that these terms are, bequeath, they're part of an ideological defense that a certain side in the controversy offers up to divert attention from underlying facts and underlying issues and underlying reporting that could have been done. And it represented a collapse of independent judgment on the part of the media, the degree to which they succumbed, the degree to which they allow their own coverage to flow into those channels that have been bequeathed to them by people who had a reason to do that. So this is a matter of a diversion and basically misleading characterization. So the short answer to your question is they need to resist that, not allow their own agenda to be overcome and to be commandeered by people who, just because they recognize that these are powerful and very appealing lines of argument that will draw an audience, and they have to insist on changing the subject back to what the subject needs to be.
Can I follow up on this question? In particular, Dr. Besser, you talked about and I think we saw how there's like data had no power to motivate people, and this underlying thing about how science is being disrespected. Is there anything there from public health and this conversation that can be brought to climate change?
I mean, it's a challenge. You know, I find it all the time, whether I'm doing something on the air and even talking to producers in the newsroom about something from a science perspective. There's a fundamental distrust of science and of holders of specialized information that worries me. And I think some of that is self-inflicted because of, you know, if there's been some discussion about the connections between the makers of products, the creation of disease, the whole marketing of drugs. That doesn't do much for increasing people's belief that science is really out for the truth. You know, is science a tool of marketing, or is science something with inherent truth? Social media is a great way for amplifying views that may be very fringe and giving them a lot more credibility than they otherwise would. So, you know, in the area of climate change, where science is overwhelmingly reach the conclusion that it's real and very much related to human activity, there are many avenues for people who don't believe that to amplify their voices and get more attention than they otherwise would. And I don't know the best way to get around that. It's an issue, I think, for journalism in general, is where are the sources people are turning for information, and how can people know that a source that they're going to is true and can be trusted. And the polarization I see of people going to the sources that they don't care if they're true, but they're saying what they believe is really worrisome to me.
Can I just make one quick comment?
I think we can.
Science Communication Network. It's a great nonprofit that I don't think has been mentioned yet, and works to do this, to make science, to have communication between scientists and journalists.
Can we go over a little bit? Is that okay, or are they going to run us in? Yeah.
Until people get rest.
So I would add one note there is I think that what we tried to suggest about the whole discussion of mediatization that we had mostly yesterday is absolutely crucial, because these notions are mediatized from the start. And it's important to understand where all of these notions, I mean the notion of climate change, enters in, first of all, the way in which it gets locked within particular understandings of knowledge and who's got it, how that travels, and how it's contested. And so if you say, we're going to take these really heavily mediatized, and which means there are lots of, as Leo Chavez would suggest, they're powerful images that get attached to them, they get repeated, and we're going to have a sheet of paper, here's some facts, and somehow we're going to drown out all of these powerful sorts of mediatized circuits with things that aren't in, these mediatized objects, with things that aren't even in those circuits, that don't have those images attached to them, is really probably not going to work. But if you understand how these mediatization processes occur, and how they occur specifically, because how it happens in terms of, let us say, an epidemic is very different than what happens in terms of cancer. When you move to the environment, it's a whole different world. So you've got to actually stop and think about, how do these things come into being as mediatized objects? What are some of the practices and the conceptions of knowledge that give them particular types of lives and kind of anti-lives, and then intervene with that kind of knowledge, rather than trying to think about these things as divorced, disconnected ideas, which I don't think will get you anywhere.
Yes.
Can I just, thank you. I just wanted to add regarding environmental health and climate change, and I'm sure you probably all addressed it, and I unfortunately may have missed this, but I just wanted some of you to comment on the fact that in journalism and in reporting, when it comes to climate change, what I often see happening is, and it is a journalist or reporter's role to be unbiased and show both sides of the story. However, in a topic like that, what happens is that they show them as equally balanced and shared in terms of giving the platform, saying that they're both of equal value. And I think it would, it's a difficult task to do for journalists, but I think it is time that we need to go in depth and address these issues as they should be talked about, and kind of show that, yes, this side says this, but this is what's actually shown, and maybe support it by evidence. And I just wanted to get your comments.
Yeah, I'd love to comment on that. I think that issue of false equivalency comes up with the coverage of climate change very similarly to what used to occur more with autism and vaccines, where the standard report was, here's one view, here's the other view, here's the issue, here's one view, here's the other view. And that's I think, not a fair approach when the science is overwhelmingly in one direction. And so a story on climate change that's laying out the climate science and then is giving equal time, or even for some issues, time at all, to, another perspective on this is, I don't think appropriate, but I don't know, from a journalism perspective, how you deal with that.
I'm reminded of your zones of deviance, zones of legitimate controversy, and I think that over the last 10, 15 years, most responsible journalism organizations would not regard climate change as being an area of legitimate controversy. And I think the balance as bias era was some years ago. We've gotten a bit beyond that. I think the bigger problem at the moment is the problem of futility and passivity on the part of readers. I think the facts have been marshaled and put very eloquently by any number of news organizations. It's just you read it and go, oh my God, why are you telling me this? What am I supposed to do? And I think that kind of restoring agency to your reader at the same time you're apprising them of some pretty numbing facts, is the challenge. And it's not easy to find the journalistic formula that enable you to both break it to them in a way that they're able to respond and rather than simply fold their tents.
Right. I want to just add one little bit to that, and it's absolutely possible that you can get to that point, because we got to that point with tobacco. We've studied a lot of news from the 1950s to current time about how tobacco has been reported, and there's been lots of interesting changes, and one is that no longer in a tobacco story does a reporter feel like they have to go to the tobacco industry to get the other side, as it were. So absolutely, and so I think you're right, we're on the other side of it. The question is, in a news environment where the impulse is to go to news you can use, changing a light bulb isn't the issue here. And so how does a journalist draw a link in the landscape of the things a community can do, like what they call in public health active transportation, which is the idea that you reduce fossil fuel use because you have more public transportation, you have more pathways, you have a built environment that creates a situation where you're not contributing to climate change, and the town of San Luis Obispo is going to do it, and it's coming through the health department. And is it useful to link that to climate change? Some people think it's really important, because if we don't name it, people don't know we're making that's one way around it. But to make that into a coherent story, where stories have plots and characters and scenes, that's the challenge for journalism, I think.
Yeah, I don't want to speak too much on this because I've got a lot of stuff on this. I got thrown out of a conference almost in Sweden because it was on journalism and stuff, and I told them that from my point of view, they didn't make much difference with climate change, that there was an animosity to it, a distrust of the government, a distrust of the claims, a sense of fraud. So it didn't matter how nicely you put it or how, clearly, etc. The people that distrust it simply distrust it.
You're talking about Swedes or Americans?
No, I was talking about Americans.
Oh.
Yeah, no, in Sweden, I just happened to be in Sweden. I was the token North American. And they wanted me partly because of the skeptics in the United States. But there's just such a distrust. It reminds me in a way, I was, followed the New York Times, it's the only American thing I subscribe to, during the election, and all their attacks on Trump. And you realize that everybody who's voting for Trump, or almost everybody, is not looking at the New York Times. So it's, the people that are looking at the New York Times pretty much agree with what the New York Times is saying, so they're not moving anybody, and then the people who favor Trump are in a different thing. Anyways, that's just the position. I don't think journalism at this point makes that much of a difference. These people are not seeking information, they're not reading about it, they live in their bubble, their silo. I have friends that are academics who send me skeptical stuff almost every day. So, that's it.
Well, it's a little like saying doctors don't matter because people continue dying. I don't... obviously, I'm paid to believe that journalism matters. but it happens to coincide with a conviction I hold anyway. But listen, plenty of people who voted for Trump were reading the New York Times. They were reading the stories about Hillary. And I think the problem with selective exposure is there. The fact is, putting the facts out there, failing to put the facts out there, leaves you in a far more perilous position than trying to put the facts in ways that compel larger audiences. But I don't think, I do agree with the basic point I think you're making, that facts, and somebody else made this point, I thought it very well, that facts only take you so far. And this fixation on fact checking is, oh, he lied. it only takes you so far because the impact of facts, the weight you attach to facts, significance you put on them is very much a function of, George Lakoff's, predispositions. But still, it is extremely important, and certainly the people coming to us now, I mean, you have no idea how the atmospherics for young journalists have changed radically in the last 3 months. And now the belief in journalism as a place, as a sanctuary, and as a place that has real social efficacy has dramatically changed. And I think that's, for us, it's a good thing. I think it's a good thing.
It's increased.
Oh, very much so, very much so.
I didn't say journalism was irrelevant to everything. I'm just saying that for a lot of people who disbelieve in climate change, you're not getting at them because they're not looking at your stuff. And, it just won't work.
I mean, people in this room would know better than I, but my assumption is most people buy climate change. The polls would indicate that most people basically say, yeah, we're in trouble. So, no. I mean, I think that for all of this resistance and pushback, I think it has had the effect of winning over.
Right. So from an advocacy point of view, you never need everybody.
No.
So there's no situation where you need everybody. So then the question is, who do you need and how do you increase their influence? And so it's really a strategic question that you can disengage a little bit from the communicative question, but then it'll join very quickly.
But note all the Republicans who are in safe seats and to be skeptics. So in a way, even convincing a lot of individuals, I mean, you have, that's what you have that political blockage there. That is hard to get around.
Did you want to say something? So maybe the last comment or question from Michael?
It's a very short comment. I don't think I hallucinated that there was a news story about mayors of Florida cities. Did I hallucinate this? Who are all believers in climate change because they can see it on the shoreline, and their immediate. So I mean, there's stuff for journalists to do with a little imagination. I mean, where's the story? Where is the shoe pinching?
The insurance companies know that it's real.
Exxon knows.
Everybody who actually has to make decisions knows that it's real.
Certainly, I think with Mohan's interesting presentations, we would want to suggest maybe balance would also involve looking at the voices of some people who are directly affected by climate change. For example, in Pacific Islands, there are lots of different, we know that this is not distributed equally vis-a-vis class and race. But at this point, I would like to very much thank 3 people, and maybe they could even stand. One of them is standing in the back, as he has been for almost 2 days. CB, as we call him, CB Brown. And Cynthia Alvarez. All of the people who came know her well because she arranged the travel and so many other things. Right there in the corner. And somebody who's put so much into this conference all the way from the beginning, including in its first instantiation when it actually got postponed for 6 months and stayed with it, Deborah Lustig. Thank you so much. The Townsend Center has been great. Thanks for the room. And now, thanks to all of the Institute for the Study of Societal Issues and the Institute for International Studies, we have a wonderful reception waiting for you in the back, so please stick around and speak more with our speakers. We would also like to give a round of applause for a really great set of presentations.